My name is Bruce Chabner. I'm a physician, a medical oncologist at the Massachusetts General Hospital Cancer Center in Boston. The manuscript that I wrote was published by the New England Journal of Medicine, and the title of it had to do with the challenge of the shortage of generic drugs for cancer treatment. There are 3 points that he made in the executive order. The first was to enforce early warning of impending drug shortages on the part of the companies. Secondly, to urge the FDA to take rapid action on applications for new licenses to market generic drugs. And the third item was to ask the Justice Department and the FDA to exchange information about possible collusion in the pricing of these drugs. It really began to surface about 4 or 5 years ago, but in the last 2 years it's become a significant concern of ours because it affects so many of the drugs that we depend on for just common treatment of cancer. Some of the basic regimens. It affects most of the common cytotoxic drugs that were developed in the 1970s, 80s, and even early 90s. So for the cancer drug field, which is a significant part of the problem, only 3 or 4 companies are really actively involved. They're in the United States. There are others overseas, but in the United States there's Bedford and Teva, which are the 2 biggest ones, and then Hospira and APP. And they make most of the 20 or so cancer drugs that are prominent on that list. And this consolidation, this limitation, the number of suppliers is the result of several factors. One is that the big fish have bought the small fish, but secondly, the lack of attractiveness of pricing of generic drugs. There isn't a great incentive for other companies to get into this field and to compete because the profit margin is very low. I think in most cases there is either 1 or 2 major suppliers. Teva and Bedford are by far the largest. The others are much smaller, and the market is very constricted for some of the most valuable drugs, such as cisplatin, 5-FU, and doxorubicin, for example. Where they may shoot up dramatically is in what's called the gray market, which are wholesalers that get into the field that purchase a drug supply and then resell it outside of the normal channels. And our hospital and others have been forced to deal with these alternative sources because of the shortage of the drug in the hands of the general wholesalers that we deal with. There are only a few large wholesalers that we deal with, but they often can't supply us with the drugs that we need. Now, the source of these gray market drugs is often not entirely known, and you know, there's always the possibility that you're buying stuff that was made outside the United States and may not be authentic. So that concerns us. We don't want to buy from these other wholesalers, but at times we have to. Their prices can be much higher. Two major elements to a shortage. One is supply, and the other is price. I'll deal with price first. The price that Medicare has fixed for these drugs, and which affects the majority of our patients, or at least a large part of our patients, and which is followed by other drug companies, is specified in the Hatch-Waxman Act and subsequent regulations as being a very, very minimal markup over what's called the average sale price, and that's something that's determined by taking figures from the producers and applying it to the price that can be charged in the next quarter. And so there's very little margin for increasing price over the course of a year, and the price doesn't fluctuate with demand. So it affects the incentives to get into the business and the profit that one can make by making these drugs. So that affects production because the companies are then forced to use their oldest production facilities to pay the least attention to the quality of the product because they're operating at the margin of profitability. And the FDA has closed down several of the large facilities because of problems with contamination and impurities. So when that happens, when a large production facility is shut down, you suddenly have a significant shortage of drug on the market. The other problem is that there's a fair amount of bureaucracy involved in getting drugs into the market, new producers. In fact, some companies recently have offered to enter the market with product that's made overseas, some large and reputable companies, but they haven't been encouraged to do so. And I think perhaps the presidential order will affect this and maybe produce some leniency on a part of the approval process at the FDA. So there are a number of other things that could be done to provide incentives, and I think I regard this market, the generic market, as being like a public utility. It's a valuable resource for the community. It's in fact life-saving for some of the patients. We all pay for the research that goes into trials. We should have access to the benefits of those trials in terms of the drugs that are used to treat cancer. If you really accept that idea, then there should be significant oversight of this and some incentives to make it happen. So with electricity, we are very careful to be sure that the supply will be there, that the governmental oversight encourages building new facilities when they're necessary and provides a profit in the price that's charged to customers. The same thing should be true of this industry. There should be incentive to produce. If you do a good job, you're rewarded by getting a reasonable profit for your effort. That isn't the situation now, where the profit is held down and there really is an incentive. Some of the incentives I've thought about are such as giving priority review to companies that do a good job of producing the drug and meeting the demand, providing maybe preferred pricing in those instances where they do an excellent job. The actual price of these drugs is so low at the present time that they comprise a very small part of the cancer drug market, and even a 30 or 40% increase in the cost of these drugs would have very little impact on the cost of medical care. Now, obviously, we don't all want increases in the cost of medical care, but here I think we have an example where regulation has unfairly compromised our ability to get the drugs. I don't think they are. I mean, the list of drugs in short supply may include now something like 20, 25, 30 cancer drugs, but it includes a number of other drugs, up to 80, 90 other drugs, and over the course of the year, more than 200 drugs have been on the short supply list. Some of these things are absolutely ridiculous. They're solutions of electrolytes or antibiotics that have been made for years. There's no real mystery at how to make these things. It's simply a matter of having a reasonable production facility and capacity. And it isn't true that it's only affecting cancer. It's affecting virtually every aspect of medical practice. The difference with cancer is that these drugs are absolutely life-saving, and some of the others are as well, but anesthetics, antibiotics, you can often find a reasonable substitute, but you can't for these cancer drugs. Yes, they are. Virtually all of this relates to injectable drugs that are produced in a vial and sold through hospitals or infusion centers. I think that ultimately it's going to require some legislation that recognizes the unique status of these drugs, the generic drug and injectable generic drugs, as being a critical resource and treats them as such, and encourages good manufacturing and gives the manufacturers a decent reward for their work. And There are several solutions to this. One is providing incentives. The other is encouraging foreign companies to come into the U.S. market. All of it depends on being able to make a reasonable profit.